mode,
Sure.
or it
You can
Yes,
try.
will.
go ahead. Thank you.
There you go.
Okay,
Looks
now
good.
it's working. Okay, so this been true. So today we'll discuss briefly about the categories of BPSD, their characteristics and their impacts on patients and their relatives, and describe the general clinical evaluation process, and discuss also how to choose the most appropriate intervention, with an update with the recent guidelines that has been published in 2024 from the CCSMH. So you will maybe recognize some slides from the guidelines. What are BPSD? Well, you all know that we're talking about non-cognitive symptoms associated with dementia, and they might also be referred as to responsive behaviors, reactive behaviors, or neuropsychiatric symptoms. We know that most people living with dementia will experience at some point some BPSD. And just to let you know that there are now specific diagnostic criteria that are recommended for agitation, depression, and psychosis. You see all kinds of BPSD that can present and their mean frequency here. And so we know that these behaviors and neuropsychiatric symptoms have great impacts on patients because it increases the cognitive and functional decline. It accelerates the need for long-term care, increase mortality, decrease quality of life. The burden for the caregiver is also increased. And unfortunately, they are also associated with increased use of physical and chemical restraints and the global increased cost for the healthcare system. So when you're faced with a BPSD, I propose here the DICE approach, which is for describe first. You need to be specific about what is the behavior present, try to describe when it happens, what could be the triggers, then investigate if they might be secondary to other factors as well. Create then an intervention plan, and then evaluate its effect and side effects, and reevaluate at some point. So for general principle about BPSD, the latest guidelines propose that you conduct a thorough evaluation for potential biological contributors to BPSD, like general medical and mental health problems. One needs to do also an assessment for possible delirium, medication review, substance pain, which is often a trigger, and hearing and vision. Also conduct a thorough evaluation of personhood using interdisciplinary approach to know about the sex, the gender, the language, the race, the cultural background, the religious beliefs of the patients. So it will be easier to build an appropriate intervention plan. Also, evaluate if there are any psychosocial or environmental factors that can be included in the comprehension of the behavior, and also to build the intervention plan. You probably all know about the PIECES tool, which is a help to assess what could be the possible triggers or factors that could rise some behaviors. So some physical factors, intellectual, emotional, the capabilities, the environment, and the social. And I won't have the time to go around all of them, but just to know that there's some reflection that goes around a behavior to try to identify every factor that could be involved in the presentation. When we jump into the creation of the intervention plan, there are like 3 types of intervention: pharmacological or non-pharmacological, which could also be divided in environmental propositions. I want to put emphasis on the fact that some symptoms are not likely to respond to medication, And you will see here most symptoms that are associated with frontal lobe dysfunction, like repetitive behaviors or activities, wandering, vocally disruptive behaviors, also inappropriate voiding or dressing, undressing, which are all associated with disinhibition in some way. And so treating that kind of symptoms with medication is considered as a restraint in some form, because it won't treat that kind of symptoms specifically. Also, resistiveness to care might not be a great symptom to treat first with medication. What are the symptoms that may respond to medication? Well, anxiety and depressive symptoms, sleep disturbance, manic-like symptoms, psychotic symptoms, severe aggression, or maybe sexually inappropriate behaviors, often when they are associated with severe aggression. When we discuss environmental intervention, the factors that needs to be considered are the level of stimulation, either visual or auditive in the environment. Also try to hide some unhelpful stimuli, give some temporospatial orientation cues, and try to build an environment that is home-like. So here you have some pictures of a very institutional ward that could increase the agitation level of the resident, contrary to more home-like facilities, which are known to decrease some kind of agitation. When I'm talking about hiding stimuli that might be problematic, here you see that the elevator are very well visible. So wandering patient will often want to jump into that elevator. If you camouflage those doors with some pictures, then it can decrease the need of the resident to fly away. So those are some examples of environmental intervention. Having an access to outdoor also is important. Some literature is discussing some security path, outdoor path where people can wander and be safe, which is good for their mental health also. When we discuss non-pharmacological intervention, some principles are to stay in your mind, like they need to be individualized to the life story and also the interest of the subject. They need to be utilized strategically to prevent BPSD at some problematic times of the day. And they should be based on residual capacities. Often long-term memory is preserved longer than short-term. So reminiscence activity could be good ways to intervene. Procedural memory, sensorial memory are often preserved the longest. So it might be useful to use those kinds of residual capacities and use also those that are validated. So what are the non-pharmacological possible intervention? First point is to educate staff and also the caregivers about dementia and also about BPSD and the way to approach them. Basic approach, the way we communicate with the patient and we understand the cognitive dysfunction. Basic strategies like validate the emotional state of the patient, diversion, trying to discuss other subjects of interest that change the focus of attention. The environment we've already discussed, and more structured non-pharmacological interventions. If you consult the latest CCSMH guidelines, you will see some recommendation about some specific non-pharmacological intervention for specific symptoms. And we put in the grade assessment the ones that have stronger evidence. Like for agitation, here you see that interdisciplinary approaches to care that include education, structured approach, individualized care, plan and also meaningful activities are usually useful. Music therapy also is often a good non-pharmacological management of agitation. We have other kind of intervention here, like animal-assisted therapy, robotic pets, physical exercise, massage, aroma well. For depressive symptoms, also interdisciplinary approaches are the most validated, with also cognitive stimulation, reminiscence therapy, exercise, and massage and touch therapy. If we discuss now pharmacological interventions, the indication are for behavior of moderate to severe intensity that poses a health or safety risk for the patients or others, because the benefits of the treatment might, in fact, should outweigh the risk. So general principles of pharmacological interventions in geriatric patients, as you know, are to start low, go slow, but sometimes you need to go to higher dosage that are recommended. Use one pharmacological agent at a time. Check often for side effects. You need to know that a complete response might take from 2 to 6 and even more weeks. One needs to consider changing agents if there is no evidence of efficacy after a few weeks of treatment. And also attempt progressive withdrawal after the patient has been stable for 3 to 6 months, stable or in remission of the problematic symptom for 3 to 6 months. The drug classes that are used for BPSD, I think you know them. There are some antipsychotics medication, either typical or atypical, some antidepressants, anticonvulsants, benzodiazepine, acetylcholinesterase inhibitors, and memantine. We will discuss them here. Just a little note first to tell you that you might want to be vigilant about pain, because undiagnosed and untreated pain is often at the root of some BPSD, mostly if you have resistiveness of care. And sometimes just routine acetaminophen or topical therapies or might decrease the agitation for some patients. Also know that SSRIs are first-line treatment for anxiety, depressed mood, irritability, lability, and there is also some effectiveness in mild psychosis and agitation, but they take 4 to 6 weeks to have a full clinical response. And with citalopram and escitalopram, the clinician might be aware that there could be a QTC increase, also some problems with GI bleeding and hyponatremia. If we discuss antipsychotics, they are indicated only for severe agitation and aggressiveness or severe psychotic symptoms. They have modest effect compared to placebo. And here are listed the ones that are validated in BPSD. You see risperidone, aripiprazole, brexpiprazole, and quetiapine with lower dose than what we see in younger adults. The change from the latest, the changes from the previous guidelines, the latest meta-analysis has shown that olanzapine is not well tolerated and might be associated with the most risk, the highest risk for mortality and vascular events. So in the 2024 guidelines, we withdrawn it from the recommendation, and it was added brexpiprazole, which has 2 or 3 studies that shows its efficacy from agitation, severe agitation in dementia. It has been approved by the FDA for agitation in Alzheimer's disease lately. So usually antipsychotics have an increased efficacy when symptoms are severe. Quetiapine is the most used medication, but there might be some problems with sedation and orthostatic hypotension. So it was put in a second line treatment in the latest guidelines. Typical antipsychotics have less favorable side effects profiles, so usually they are used only in an emergency case. Side effects of antipsychotic medication, you know that they are prone to give some extrapyramidal symptoms like Parkinsonism, also akathisia. Akathisia might sometimes be mistaken for agitation. Tardive dyskinesia, which could affect about 1/4 of the elderly patients after 1 year of treatment, which might be severe in certain patients. They could also give some cognitive disorders, falls, drowsiness, hypotension. Some may be associated with anticholinergic symptoms, some infections, peripheral edema with Risperdal mostly. Some can give some metabolic syndromes and weight gain, and they are contraindicated usually for Parkinson's disease or Lewy body disease, except for quetiapine and clozapine. So they need to be used with an informed consent because there is an increased risk for mortality. The odds ratio are about 1.54, about 4.5% of residents taking a typical antipsychotic compared to 2.6 taking a placebo. And olanzapine, as I've previously said, at the highest risk of mortality in the latest meta-analysis. The prolonged treatment, more than 3 to 6 months, might be associated with an increase in mortality risk, and they are also associated with higher CV events. Again, olanzapine with the highest risk here. So patients with dementia taking antipsychotics medication should be followed closely and the indication reassessed regularly. Benzodiazepine now are not a first line of treatment for BPSD. They have non-specific sedative and anxiolytic effects. They are associated with falls, ataxia, drowsiness, altered consciousness, delirium. They can give paradoxical disinhibition. When one wants to use short-term benzodiazepine treatment, they should use the one with the metabolic profile, which is the most favorable to the elderly, which are mostly lorazepam and oxazepam. Cholinesterase inhibitor and memantine are not used to treat severe BPSD, but they might have a role in preventing the apparition of BPSD when started in mild to moderate Alzheimer's disease. They might be efficacious in reducing slight apathy or irritability, but they won't be effective for severe agitation or in Lewy body dementia, they are the first line treatment, but those two kinds of medication can increase frontal symptoms. So usually they are contraindicated when you have a frontal syndrome profile. There has been some occasional worsening of BPSD when they are stopped. So the clinicians need to be aware of that. So if we go back to the latest recommendation from the CCSMH, for moderate agitation, there is a strong recommendation to use citalopram in first-line circumstances. And in severe agitation, we put aripiprazole, brexpiprazole, and risperidone in first line. And if there's non-response, it's suggested to switch from either risperidone to aripiprazole or brexpiprazole. Quetiapine might be recommended in a second-line treatment and a typical in third line. There is a place for possible Nabilon and carbamazepine efficacy. And in the treatment of acute agitation, short-acting antipsychotics available in the PEROS or intramuscular form could be used. We added a recommendation against using, starting a cholinesterase inhibitor or memantine for moderate to severe agitation. Again, it's not a treatment. It might prevent the apparition, but it's not a treatment. Against olanzapine, because of the argument I've just explained. Against trazodone, mirtazapine, sertraline, fluoxetine, and other antidepressants, mostly because there are not much out there for discussing their efficacy and tolerability. Against acid valproic, it is well shown that it increased the confusion and have many major side effects in dementia patients. Against polypharmacy, and against long-acting injectable antipsychotic, except if there is a psychotic disorder. For specific disease like frontotemporal dementia, just a little word that first-line treatment is usually with serotonin agents like SSRI or trazodone. And the clinician needs to know that memantine and acetylcholinesterase inhibitor can worsen the behaviors. Sometimes atypical antipsychotics might be needed if there is a high level of severe aggressivity. Lewy body dementia or Parkinson's disease dementia. First line treatment would be to lower dose or wean off of medication that could increase psychotic or cognitive side effects like anticholinergic agents, COMT inhibitor, dopamine agonist, to be left usually only with L-DOPA. The first line treatment is a cholinesterase inhibitor, and usually typical and atypical antipsychotics are contraindicated because of hypersensitivity of these patients to severe extrapyramidal side effects, but also delirium, except for quetiapine, which has very little efficacy demonstrated in double-blind studies, but often used because of favorable side effects. You see that it is very low dose quetiapine that are used, but often sedation and hypotension are limiting. And clozapine, which is the treatment of choice at low dose, but needs a close follow-up and regular blood test. We added in the latest recommendations some recommendation about deprescribing of medication in BPSD, mostly antipsychotic, because it is well known that it's still a case in Canada with high levels of, what we can call inappropriate prescription of antipsychotic medication, mostly in long-term care. At least in Quebec, that's still the case. So it is recommended to try to deprescribe antipsychotics in people with dementia who do not have a history of severe agitation, psychosis, or a potentially appropriate indication for antipsychotics. And when you try to deprescribe, the clinician needs to consider the current BPSD, the duration of the treatment with an antipsychotic, the dosage that was required to stabilize BPSD, the initial severity of agitation and psychosis, because, if it was very severe and it need a high dose to reach a remission, then one might need to be a bit more cautious when deprescribing, and usually try to describe the dose by 25 or 50% every 1 to 2 weeks until it is discontinued, or at the lowest effective dose if BPSD worsens. Just to add some reference or some links that might be helpful for you to continue to read about that, but also with that great series of ECO webinars. You will see on the behaviors in dementia link that you will be able to access the latest recommendation and also multiple tools for practitioners working in that field. So that's it for my little part. I'll